Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Kemi Obajimi. Today's episode features expert perspectives on new and emerging therapies for the personalized care of patients with HER2-positive gastroesophageal adenocarcinoma and biliary tract cancer. This episode is part of a larger educational program titled Innovations in HER2-Positive Gastroesophageal Adenocarcinoma and Biliary Tract Cancer, a practical skills course on new and emerging targeted therapies. This podcast features Dr. Amit Mahipal, Director of the Gastrointestinal Medical Oncology Program, Ruth and Donald Goodman Endowed Chair in GI Oncology, Professor of Medicine and Senior Attending Physician at the University Hospital Siedman Cancer Center, Case Comprehensive Cancer Center at the Case Western Reserve University in Cleveland, Ohio, and Dr. Shubham Pant, Professor of GI Medical Oncology in the Department of Investigational Cancer Therapeutics, Director of Clinical Research, and Associate Director for Early Phase Drug Development at MD Anderson Cancer Center in Houston, Texas. They will be providing a brief overview of biliary tract cancer and gastroesophageal adenocarcinoma and discussing approved HER2-directed therapies for these diseases, the mechanisms of action, efficacy and toxicities of the approved agents and optimal management strategies, key ongoing trials of HER2-directed therapies, and challenges faced by healthcare professionals in the management of patients with biliary tract cancer and/or gastroesophageal adenocarcinoma. For more information on Dr. Mahipal and Dr. Pant, along with a link to the complete program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say on this important topic.
Welcome to our podcast on HER2-positive gastroesophageal adenocarcinoma and biliary tract cancer. I'm Dr. Shubham Pant. I'm a professor of GI Medical Oncology at the MD Anderson Cancer Center in Houston, Texas. And with me today is Amit.
Hi, I'm Dr. Amit Mahipal. I'm the professor of oncology at Case Western Reserve University.
On our agenda for today, we're going to provide a brief overview of BTC and GEA, that's biliary tract cancer and gastroesophageal adenocarcinoma. We're going to talk about approved HER2-directed therapies for BTC and GEA and their mechanisms of action. We'll also talk about efficacy and toxicities of the approved agents, and more importantly, optimal treatment strategies. We're going to also discuss the key ongoing trials of HER2-directed therapies in BTC and GEA. And finally, we're going to end with challenges faced by healthcare professionals in the management of patients with BTC and/or GEA. Amit, I want to kick off this activity by asking the general question: which specific biliary tract cancer and gastroesophageal adenocarcinoma are commonly associated with HER2 positivity? That means, is there a subtype which has high HER2 expression in BTC or GEA?
For the BTC or biliary tract cancer, we typically divide them into like intrahepatic cholangiocarcinoma, hilar, and then extrahepatic cholangiocarcinoma and gallbladder cancer. The highest rate of HER2 expression tend to be in gallbladder cancer and extrahepatic cholangiocarcinoma, with rate approximately around 20% or so. And gallbladder can be as high as even 30%, depending on what studies we're looking at. As compared to intrahepatic cholangiocarcinoma, where the rates are actually pretty low, probably less than 5%. It's in the GE junction or gastroesophageal cancer is not entirely clear, but GE junction cancer tend to have a little bit higher rates. There is some differences between the intestinal and diffuse type in terms of the HER2 expression, but again, we'll recommend testing for all of these subtypes.
What you're telling me is that all patients with gastroesophageal adenocarcinoma and biliary tract cancer should be HER2 tested, regardless of where the origin is. If it's gallbladder, intrahepatic cholangio, extrahepatic cholangio, because it can happen anywhere. And similar case with gastroesophageal adenocarcinoma. Is that correct?
Absolutely correct. So I just want to again clarify, even though there are differential rates based on the different subtypes, especially of like bile duct cancer, we would still recommend testing for everyone because even if it's a low rate of expression, if we can find it, I mean, those patients can benefit a lot from HER2-directed therapies that we'll be talking about in a few minutes.
The first thing is if you don't test, you will not find. And the second thing is no patient left behind, right? So that's very important. So tell me, Amit, and this is a very clinical question because we're not pathologists. We love to play pathologists as oncologists sometimes and radiologists. But in clinical practice, how do you assess HER2 positivity in your patients with biliary tract cancer and gastroesophageal adenocarcinoma? And what are the nuances of this? Because I know it's like an onion, right? There are multiple layers to this.
Yeah, so that's becoming a tougher and tougher question. Like, how do you test HER2? What methodology do you use? Traditionally, HER2 testing has been done in breast cancer, and a lot of these data came from breast cancer and tried to apply to different other GI cancers. And what we have found is the HER2 expression in breast is very different than HER2 expression in GI. So pathology have different IHC scoring for gastrointestinal cancer, especially talking about GEA and BTC, compared to HER2 expression testing by IHC even in breast cancer. I think standard of care, if you want to test for HER2 positive, should be immunohistochemistry. At least for gastric cancer or gastroesophageal cancer, what we recommend is you test for by IHC first. And if it is 3+ is positive, if 0 or 1 is negative, and if it's 2+, then you test like a reflex test to FISH. And if FISH shows overamplification, then patient is considered HER2 positive. For biliary tract cancer, you can use the same approach, but the indication for treatment is for patients who are HER2 3+ by IHC. So it's restricted to immunohistochemistry. Again, for both cancers, so HER2 testing should be done by IHC as a first step. And if they are 2+, then could be considered FISH. Then there are other tools like NGS. You can look at mRNA amplifications, and they may correlate very well with IHC or protein overexpression. But just again, to be clear, some of the drugs are not approved just based on HER2 mRNA amplification. They're mainly approved based on IHC testing and FISH testing if IHC is 2+.
If I had to drill this down, Amit, what you're saying is you need to test by immunohistochemistry. So when you look at the report patient with biliary tract cancer comes in or gastroesophageal adenocarcinoma, send that test off for IHC, quick, cheap test to do in a way. But what about next-gen sequencing, Amit? You talked a little bit about, because those are two big tests we send. Like, so a patient goes and they have next-gen sequencing, HER2 amplification. What do you do with that?
Correct. I mean, again, we will talk about the treatment options. For right now, at least the FDA approval is only based on the protein overexpression by immunohistochemistry and or FISH testing, and not based on HER2 overamplification. What we have found is patients who are HER2 overamplified, they are very, very highly correlated with protein overexpression as well. Unfortunately, it's not 100%, but very highly correlated. And if you do have a patient with HER2 amplification, if you found by NGS, if your ISC has not been done, I would strongly recommend to try to do it. If you need extra tissue, go for a biopsy to get extra tissue to do it. But I think that's a patient you should strongly consider for HER2-directed therapy.
What about everybody's favorite kid, as we say, ctDNA, circulating tumor DNA? When did you bring that into the mix?
Yeah, at least for initial testing, I think we should not rely on ctDNA, especially for RNA amplification. They can pick up some DNA amplification, but many times if you ctDNA would miss HER2 positivity. So I think just to rely on ctDNA or circulating DNA positivity as an initial step is not a good practice. I think we'll definitely want to have a tumor tissue testing. Make sure to do it again, as I said, by IHC, FISH, and other methodology just to make sure they're positive or negative. But circulating DNA as an initial test is not a great test. However, sometimes it can help in some monitoring of patients who are on HER2-directed therapies, where we can talk about later on. But at least initial testing, we would not recommend doing circulating DNA as for HER2 testing.
Yeah, I agree with you. I think those some folks really are in the ctDNA camp, but I'm with you there that tumor tissue is what we need to go for if we really need to. What about retesting, Amit? Like, do you in gastroesophageal adenocarcinoma or in, let's say, biliary tract cancer, somebody got Gemcis durva frontline or Gemcis pembrolizumab frontline, would you test them for HER2 again and you had the initial biopsy, which is HER2 amplified? What about gastroesophageal adenocarcinoma, somebody who had HER2-directed therapy, let's say it's trastuzumab frontline? So how do you distinguish between the two?
Right. So there's some interesting data that is coming out that shows patients who are HER2 positive and went on to HER2 therapy and then they progress. Should we consider another biopsy at that time to see if they still retain that HER2 positivity before considering second-line HER2-directed therapy? I think in the biliary tract cancer, where we're just giving chemoimmunotherapy and not HER2-directed therapy as a first line, and even if they're positive at baseline, I'm not sure at progression their HER2 positivity would change since they did not receive HER2-directed therapies. But there are people in the camp who would really strongly advocate, at least for the patient gastroesophageal cancer who have received HER2-directed therapy and have progressed, to retest them, make sure they're still HER2 positive. And if that's the case, then go for the second-line therapy. Again, we have not done this as prospective trials, but I think it's a good idea, good practice, just to make sure they've not lost the HER2 positivity.
What you're saying is there is a difference in gastroesophageal adenocarcinoma. If you've had previous HER2-directed therapy like trastuzumab, maybe you do want to retest them before you expose them to trastuzumab deruxtecan, because again, these therapies are not without toxicities. However, in biliary tract cancer, if they've not, the front line is GemCis with a checkpoint inhibitor, you really don't think that HER2 status would have been changed just because they did not get a prior HER2 therapy. And you really potentially don't need to retest them. You can just take the first test.
All right, Shubham, now I'm going to ask a few questions about HER2-directed therapies in general. What are the FDA-approved HER2-directed therapies for patients with biliary tract cancers?
Yeah, exciting times. If you'd asked me this question, like 2 years ago, I would have said nothing. However, things have changed dramatically. The whole landscape is changing. There are 2 drugs out there, Amit, which have been approved, which have gained accelerated approval for second line, after front line, basically. One is a drug called trastuzumab deruxtecan, which we know for a long time because of breast cancer. Our breast cancer colleagues started with HER2 positive, then they went to HER2 low and went to HER2 ultra low. How low can you go? But that's just breast cancer. But for us, again, as you said, patients need to be, the approval was for HER2 3+ IHC. And this was based on a trial called Destiny Pan-Tumor 02, in which essentially patients with different HER2 amplifications, it was not even overexpression, it was not even biliary tract cancer, it could be pancreatic cancer, ovarian cancer, some other gynecological cancers, were treated with trastuzumab deruxtecan as a basket trial. And the response rate in HER2 3+ was about 56% in these patients. So that's how that was approval for trastuzumab deruxtecan. The second one is what I call the new kid on the block, is zanidatamab. And this is a very interesting agent that we'll talk about the mechanism of action a little bit later. But essentially, this has also been approved for HER2 3+, where it showed response rate of 52% in these patients. Now, the interesting thing about zanidatamab was most of the other HER2 trials have been done as a basket trial. So we have others like trastuzumab pertuzumab, which is part of the NCCN guidelines. We have tucatinib trastuzumab, which is also part of the NCCN guidelines, and trastuzumab deruxtecan, which got its approval based on a basket trial. The unique thing about the zanidatamab trial, which is called Horizon BTC-01, was that this was an exclusive trial done exclusively in patients with biliary tract cancer. It was a global trial. 80 patients were accrued. This drug was given IV once every 2 weeks, and patients got scans every 2 months. And like I said, the response rate in the HER2 3+ was about 52%. More interestingly and exciting for us as clinicians was the duration of response. That means the patients got a response, they kept on get their duration of response of 14.9 months, which I think is fairly remarkable in patients with refractory disease to frontline therapy. The overall survival for HER2 3+ patients was 18.1 months, the median overall survival, which treating biliary tract cancer, that is fairly remarkable in this setting. So excited to have not one, but two drugs approved in this rare setting for patients.
Thank you, Shubham. So just to recap, so there are 2 drugs that are now approved for HER2-positive bile duct cancer. One is trastuzumab deruxtecan, and second is zanidatamab, with zanidatamab trial being really studying just the bile duct cancer population, and TDX or trastuzumab deruxtecan doing a more of a basket trial. And what line of therapy is it approved? Is it first frontline or second line or later?
Yeah, it's not frontline. This is after frontline therapy. So after frontline therapy is technically go to a second or third line. So it is after frontline therapy that these therapies are approved.
Okay, so as long as patient has progressed or not tolerating one line of therapy, patients can receive HER2-directed therapies. And based on this response rate or excellent response rate, we'll probably recommend going for these therapies more in a second line rather than third line, because you don't want to waste the opportunity if the patient has targeted therapy available for these patients. And we typically don't see such a high response rates with bile duct cancer, definitely not in second line or later.
I would definitely agree with that. You're right.
Absolutely. So tell me a little bit about this mechanism of action of zanidatamab and how is that different from trastuzumab or TDXD? I mean, we hear all these anti-HER2 drugs and sometimes hard to wrap our mind around, like, how are they different?
Well, start with trastuzumab deruxtecan. Folks know about the mechanism of action. It's an antibody drug conjugate. That means it's akin to a smart bomb. It's like a heat-seeking missile, right? And the target is HER2, which blinks brightly, and it just attaches and releases the payload inside it. So that is your trastuzumab deruxtecan, more like a guided missile. Then you have zanidatamab, which is a very interesting construct. It is a bispecific biparatropic drug. What do I mean by that? This does not bind to CD3, so it really does not have things like CRS, a cytokine release syndrome, but this binds to two domains on HER2 called ECD2 and ECD4. So that's extracellular domain 2 and extracellular domain 4. Interestingly, these are domains that trastuzumab and pertuzumab bind to, but because it's two drugs in one, it actually has a better impact, better receptor internalization. So it has certain ADCC, so certain ways that it acts, which could be more beneficial or efficacious for the patients than just using single agents of two drugs. So it's almost two drugs in one, but it leads to more synergism and more potency having those two drugs in one. So it's called a bispecific biparatropic, not to be confused with other bispecific that are approved for lymphoma, let's say, where this does not cause the CRS because it just binds to these two domains on HER2.
Do you think that's why zanidatamab, not cross-trial comparison, seems to have more efficacy both in bile duct cancer and GE junction cancer or gastroesophageal adenocarcinoma at single agent compared to, say, trastuzumab?
Yeah, I think so. I've treated before all these drugs came by, approvals, trastuzumab deruxtecan and zanidatamab. We treated patients with biliary tract cancer with trastuzumab, combo of trastuzumab, pertuzumab. I did see some responses in that, but not to the level that I'm seeing with these two drugs now.
We talk about efficacy, talk about some of the mechanism of action. Let's talk a little bit about adverse events. What kind of side effects do we see? So let's start with zanidatamab. What's the most common adverse events that we tend to see with this in your clinical practice? And I know you were involved in the trials as well. So let's give your thoughts on that.
Yeah, folks know a lot about TDXD because of breast cancer, other cancers. Folks have used it a lot. Zanidatamab, interestingly, the first approval wasn't biliary tract cancer, so folks haven't used it a lot. I've had a number of patients with it, as you know, on the clinical trial, and now I've actually commercially treated a few patients with it since it's been available. Main side effect that you need to look out for zanidatamab is diarrhea. So what you do is you talk to your patients just like I would talk about giving irinotecan. I educate them about it. I say, here's Imodium, keep it next to you. 2 pills with every loose stool, 2 pills every 2 hours. We have this, what we talk about with irinotecan related diarrhea. You hydrate yourself. If it's not happening, then we can give Lomotil. There is a dose adjustment for zanidatamab. It starts at 20 milligram per kilogram. And if you cannot tolerate it, you can go down to 15 milligram per kilogram. So it depends, but this is very well tolerated. The other thing with zanidatamab that you have to keep in mind is that patients need pre-medication. So it can have infusion-related reactions. All patients do need pre-medications with Benadryl and with a steroid and H2 blocker maybe. So it needs a pre-medication because it can cause infusion reactions. But otherwise, honestly, it's fairly well tolerated. Trastuzumab deruxtecan, again, the common side effects, nausea, anemia. It's like giving chemotherapy, I think, for our biliary tract cancer patients. With my biliary tract cancer patients, I do see them get nausea, fatigued, anemia, neutropenia. So classic chemotherapy side effects. Though I said it was a targeted therapy, it does have chemotherapy-related side effects. Obviously, the rare but deadly, which can be really morbid, associated with high morbidity, is your interstitial lung disease. Recognize that early. Pneumonitis, make sure you hold the drug, treat it early. That's very, very important. Even if you see some little changes in the CT scan of the chest, or normally what I say to my patients, I say, hey, when you walk, do you get more winded? Are you walking up the stairs and you cannot walk anymore? So little clues which would give me some idea about if they're getting this toxicity. But again, it's reversible. It's easily treatable, but we just need to be aware of this toxicity. But they're different drugs as far as toxicity are concerned, definitely.
Yeah, so definitely seems like very different side effects. But I think just for a recap, I think the 1 or 2 key side effects for zanidatamab will be primarily diarrhea and maybe some infusion-related reaction. And then for TDXD will be cytopenia, fatigue, and more importantly, just to watch out for pneumonitis or interstitial lung disease.
That's right.
Great.
Amit, we've talked about biliary tract cancers. Let's talk about gastroesophageal adenocarcinoma. Could you give me a little bit of treatment landscape for HER2-directed therapies for patients with GEA?
Yeah, so HER2-directed therapies for GEJ actually has a little bit more and has evolved over years. One of the first trial, the TOGA trial, which led to approval of trastuzumab in combination with chemotherapy was in 2010. And then we have another combination of chemotherapy plus pembrolizumab and chemotherapy plus trastuzumab as well, approval in the first line setting. Then in the second line setting or later, we have TDXD or trastuzumab deruxtecan. For GEJ junction cancer, we have approval in the second line or later setting for patients who have progressed on trastuzumab-based combination chemotherapy.
Okay. Tell me about what HER2 expression levels are they approved for?
As we just talked about, so HER2 expression for gastroesophageal cancer, we require it to be ISC positive, so ISC 3+. In case if they're ISC 2+, if they're FISH positive, they can receive HER2-directed therapy, so they're eligible to receive for HER2-directed therapy. So either HER2 3+ by ISC or 2+ with FISH positive.
Clinical practice, what's been your experience with trastuzumab deruxtecan, AEs? What do you see in your clinical practice?
Just talking about trastuzumab, we use it again in combination with chemotherapy or chemotherapy plus immunotherapy if their CPS score is 1 or higher. So most of the side effects are not driven by trastuzumab. I would say that most of the side effects are actually driven by chemotherapy and that we have seen with a lot of chemotherapy combinations. Trastuzumab does affect the heart, so that's something we're always cautious about, and we have to do either echocardiogram or MAGA on regular basis just to make sure your ejection fraction is not decreasing. And if it is, then get a cardiologist right away, and you may have to interrupt the treatment. We talk about TDXD, I think, as Shubham, as you mentioned, has the kind of same side effects, like as a chemo-like side effects, like cytopenias, fatigue, nausea, and then just to watch out for interstitial lung disease. At least in the trial with GE junction cancer, we see about 10% rate of interstitial lung disease. So it's not that infrequent. So just to keep an eye for those. Obviously, if someone develops pneumonitis, that can even lead to a fatal event in rare cases. So I think early recognition and treatment with steroids, holding treatment can really help and prevent pneumonitis in these patients.
Okay, so similar side effects and everything. What you see, TDXD more like chemo, trastuzumab is in combination with chemo, but overall, we've used it for a long time. So Amit, coming to what we've talked about, the new kid on the block, right? Zanidatamab. Now it's got an approval in BTC. What do you think about its chances in gastroesophageal adenocarcinoma? Where are we? What trial is going on right now?
Sure. So Shubham, as you mentioned, right, zanidatamab has very high single agent activity, which we typically don't see just with single anti-HER2 antibody like trastuzumab. We saw that great activity in bile duct cancer, and now they're trying to test in other HER2-positive cancers like GEA cancers. So they're looking at zanidatamab in combination with chemotherapy, with or without anti-PD-1 inhibitor like tislelizumab, for patients who are HER2 positive with advanced gastroesophageal adenocarcinoma. So it's a first-line trial, randomized phase 3 trial looking at addition of zanidatamab to chemotherapy plus minus tislelizumab.
Hopefully, we'll potentially have more options for our patients with HER2 overexpressed gastroesophageal adenocarcinoma, but we have to wait for the readout of this trial, which we hope should be coming soon.
Shubham, what are the challenges faced by healthcare professionals in the management of patients with both biliary tract cancer and gastroesophageal adenocarcinoma? I mean, both of these cancers tend to be somewhat on the rarer side. So there's some unique management for these cancers, especially now we're talking about HER2-directed therapies in particular. What is the challenge for the HER2 testing for your patients?
Tissue is the issue, right? And the three most challenging words oncologists can get from pathologists is QNS, right? Quantity not sufficient. So it's really challenging because, again, you do tests for multiple things, right? There's some tissue goes for next-gen sequencing, then you're trying to do IHC on it. So for us at MD Anderson, we really try hard. Like if a patient has had a biopsy and we cannot do the NGS because it's not sufficient, if there's something which can be biopsied and is appropriate, then we definitely try to go for it and try to get some tissue. If not available, then I kind of reflex to ctDNA, but something so that I know I've tried to get some kind of sequencing for these patients. Because like I said before, if you don't look, you will not find. I really try to do all I can. Because the thing is, Amit, folks may say, oh, let's do it frontline. We're going to treat BTC with Gemcis durva, and there's not enough tissue. And when they relapse, we'll do the biopsy. But in my opinion, what happens is by the time patient progresses, and then you're doing the biopsy and they're waiting to start the second line therapy or some clinical trial. So I think really NGS testing in biliary tract cancer has moved to the forefront. I think because it tells us, options for patients' clinical trials. As we know, there's a phase 3 frontline trial going on with zanidatamab in biliary tract cancer, so it can help me identify patients for that. So I try to get it as early as possible. For gastroesophageal adenocarcinoma, obviously, you need to be checking for claudin expression, for HER2 expression, for PDL1. Though I'll tell you, I'm always confused about like the PDL1 percentage, right? Is 1% good? Is the 10% good? The claudin, is it a 2+ staining, 20% staining? I think in GEA, more than anything, pathologists try to keep us on our toes. But I'm hoping they could just come up with that easy HER2 1+, 2+, 3+. 3+ is great, 1+ is negative. So we don't have to peel that onion, as I say. But I try to do it as early as possible for testing.
What would you do? You mentioned like quantity not sufficient, and you have a patient like this is something we commonly face. Do you go ahead for do another biopsy before you start first line treatment, or do you try to do during the first line treatment? Because I totally agree. Once they progress on first line and then you're trying to do biopsy and, then you're trying to do second line therapy, sometimes you don't want to wait too long when the patient is progressing on the first line itself, right? How do you decide, right, when to treat the patient with the first line therapy or just wait for another biopsy and doing those HER2 or NGS testing on that before you actually initiate treatment?
Obviously for GEA, I want to get at least those biomarkers back because it can change the treatment that I'm giving them to front line. For BTC, maybe less because really we can use the target therapies in the second line, like FGFR at each one, and HER2 more for GEA than for BTC. I mean, a BTC I don't get it. I think this patient need to start therapy. I start them, and then I try to get it sometime during the course, honestly.
That makes sense for GA because we have approval in the first line and it makes a huge difference, obviously, in the first line setting. So it's really important to get biomarker testing. If you don't have enough tissue, just go for repeat biopsy before you start first line. What you're saying for the BTC, at least you can start treatment, but regardless, you should try to get biopsy then as soon as possible, even if they're started in the first line. Don't wait for the patient to progress on the first line therapy before doing a repeat biopsy.
That's accurate. What do you think about insurance coverage issues? Maybe less of an issue for me, maybe more for you. But what do you think in the community? Any problems with testing?
I mean, these are FDA-approved tests. Nowadays, at least for biomarker testing, there should not be any insurance coverage issues. And if there is, I mean, we can always obviously appeal those issues. But in general, I think for insurance coverage for HER2 testing or NGS testing for any patient with advanced cancer should not be an issue for these two cancers. How do you keep up to date with this treatment guidelines and relevant literature in the field? Like it's so complex, right? As you were mentioning, the HER2 positivity in breast is so much different. And then even with BTC and GEA, there might be some nuanced differences. So how do we keep up? What would you recommend for oncologists who might not see these patients that commonly, but still see them enough to make sure they get the best treatment?
That's a tough one, right? So we are blessed, me and you, that we focus on a few tumor types, mostly GI cancer. So we were able to maybe drill down. Even with that, it's getting difficult, honestly. Like just all GI, there's so much change in all the cancers. So it's still challenging. But I really feel for a community oncologist who could be seeing a breast cancer, then a colon, then a lymphoma, then some other sarcoma, some other cancer. It's very hard to keep up. So what I would say is, listen to podcasts like this, which is important. And what we really do is just do the next gen sequencing and then refer to NCCN. You'll be surprised. I've had a chat with a few community oncologists, even after the approval of, let's say, TDXD and zanidatamab for BTC, where they're like, oh, I'm starting them on trastuzumab because that's all I have. And then it's just about education, right? Just education, getting ahead of it. People like you and me having these chats and educating folks that there are approved therapies out there for HER2 amplified biliary tract cancer, because that's a very rare. Gastroesophageal adenocarcinoma still is a little bit more common, and HER2 has been tested there just because of the TOGA trial. Trastuzumab has been around for a long time. So I don't think that's so much of an issue. Maybe retesting before TDXD could be an issue. But in BTC, definitely, because it's so rare, somebody might be seeing one in a year in their practice, right? Or maybe a couple in a year. So it's just about, I think, just about education, and more education on it.
Right. They can certainly go to ASCO guidelines or NCCN guidelines, but again, it's so hard to keep up. And these guidelines try to keep up to date as much as possible. These things are obviously present at different conferences. And I would again stress that in addition to NGS, we need to do HER2 testing for both these cancers. I would even argue for all GI cancer. But again, our focus topic is both GEA as well as BTC. So Shubham, just talk a little bit about the sequencing of HER2-directed therapies. I guess we're not there yet in bile duct cancer, but what are your thoughts? Is that something coming up? And obviously for GE junction, we have more than one therapies available. So there you could consider sequencing, but what are your thoughts on that?
For GEA, trastuzumab frontline is used, and then you can use trastuzumab deruxtecan in the second line setting, right? As far as approval is concerned. For biliary tract cancers, again, after frontline, you could use trastuzumab deruxtecan or zanidatamab in the second line setting. People ask me in conference all the time, oh, which one would you do first? And honestly, both are good therapies. Both have good efficacy, look fairly similar. These are good therapies. So I would treat patients with this. As you said before, Amit, it's important to get it early. So we're not waiting for third line setting, just these patients, we can get them in second line setting. The difference that I do feel is in the toxicity. I sometimes feel like continuing trastuzumab deruxtecan for patients with BTC, they get the nausea, fatigue, anemia, thrombocytopenia, and they've just come off 6 to 8 months of gem-based chemotherapy with checkpoint inhibitor. Then they might not want to jump into another chemo-like regimen. For them, they sometimes prefer zanidatamab. AE-wise, at least in my opinion, it's a little bit easier to manage, but again, different toxicities, and I would leave it to the provider to make that decision along with discussion with their patient.
Can I just ask a follow-up question? Like for BTC, we have two drugs in the second line or later setting, right? Both zanidatamab and TDXD. But if someone say you started zanidatamab just because the patient already got chemotherapy, just a break from chemo and just pure antibody, once they progress on zanidatamab, would you consider TDXD or would you consider some other chemotherapy? I guess there's no data.
Yeah, tough question, but no data, as you said, but I would biopsy them again. And if they're HER2 amplified, yeah, sure, I would try TDXD because I think you could sequence them because I think they're different mechanism of action, right? Like zanidatamab binds to the outside, kind of outer domain of HER2, ECT2 and 4, whereas trastuzumab deruxtecan just has a different mechanism of action. So I would definitely give that opportunity to my patient, provided they were still HER2 amplified. To wrap up, we've talked about the now approvals, but what about the next? What do you think about emerging HER2-directed therapy that's on the horizon for patients with gastroesophageal adenocarcinoma?
One of the things that we just briefly talk about is zanidatamab being studied in the first line setting in combination with chemotherapy, with or without immunotherapy. As I mentioned before, I think we can make really a huge impact in the first line trials, right? Or first line treatment for these advanced patients if we have a drug which is very, very active. So hopefully with this combination, we hope that we can have a better response rate and better outcome for these patients and ultimately leading to better survival. In addition, there's a lot of anti-HER2 therapies being developed for different kind of cancers, especially obviously breast cancer. And we hope some of those therapies could be applied to our cancers if they come at positive, including cellular therapies as well. So we'll have to see what the data shows. Again, I think primarily based on the breast cancer data and then branch out to these other somewhat rarer. But as we mentioned, like in gastroesophageal biliary tract cancer, the rates can be high as 20 to 30%, depending on the subtype of these cancers. Shubham, in terms of the bile duct cancer, what do you think would be the future? Would we see that something in the first line setting, or what are your thoughts?
Yeah, I'm really excited. Again, these drugs look very active in the second line setting. So yes, we have two trials open actually. So one is for zanidatamab. This trial is frontline treatment naive patients. They get chemotherapy with gem-cis with one of the checkpoint inhibitors with or without zanidatamab. And the interesting thing about this trial is patients could have received up to 2 cycles of gemcitabine and cisplatin with the checkpoint inhibitor. As you know, cycles are given day 1, day 8, 21-day cycle. So they could be 6 weeks into treatment. You could still enroll the patients just to give flexibility in this rare patient population. Super excited about trying to get in the front line for our patients to get more options. We also do have the trastuzumab deruxtecan with a checkpoint plus a TIGIT bispecific, so check PD-1 TIGIT trastuzumab deruxtecan as one of the 3-arm studies. Third arm is standard of care, essentially. So really excited to move these therapies in the frontline setting. The trials are ongoing. If folks have these trials open or they have some trial areas near where they are, I would highly encourage them to refer their patients there or if they have it in-house, then I would encourage accrual on these trials because they're really important trials for the field. Excited about that.
Absolutely. What are your final thoughts, Shubham?
For BTC, I think we call it the lung cancer of GI cancers, right? In a way. Or we try to call it, because it's a heavyweight targeted therapies. Folks could argue with colorectal cancer, the same thing, but I think for our discussion, we'll call it BTC because you have all these FGFR and IDH1 and immunotherapy, and now you have HER2 agents, which can be targeted. I think the future is bright, and it really shows what we can do for these rare malignancies, that we shouldn't forget these rare malignancies. And they are targets, and though it might be a small number, but there are patients who are being diagnosed with this. So I think we should really strive to improve the outcomes for patients. I'm super excited about the future of drug development in biliary tract cancers. Amit, what about you for gastroesophageal adenocarcinoma?
I would really echo your comments. The biggest thing is we need to test, and test. So HER2 testing, just wrapping up, is IHC. It's very easy. Almost every single lab pathology, wherever the cancer center can do it. They've been doing it for breast cancer. But again, the criteria is a little bit different, so they can easily apply to this gastroesophageal and BTC cancer. The biggest step I think I would suggest is to do testing. It would be better if we can do a reflex testing, because I think when a patient comes to an oncologist, they've already been diagnosed for a couple of months before they actually get diagnosed with that particular cancer. And then they want to start treatment next day. And while we are awaiting these biomarker testing. So it'll be great to have a system where we can do reflex testing, including HER2 and NGS testing, so that when the patient comes in, we have all the biomarker data and we're discussing with the patient what the next step would be.
Yeah, thank you.
Thank you very much, Dr. Mahipal and Dr. Pant. And thanks to you, the listeners, for joining us. As a reminder, to view the full program on innovations in HER2-positive gastroesophageal adenocarcinoma and biliary tract cancer, a practical skills course on new and emerging targeted therapies, on the Clinical Care Options website, please click on the link in the show notes. As always, thank you for listening.